Hi guys, I'm Zoom user. This is Rachel, and it's not letting me change my profile name.
Hello.
Hi George. I think all of the content for the atlas is now inserted, so it should be fairly similar, or should be pretty much identical to the OSU version.
All right, great. Actually, I tried the link that I had in the course from 2 years ago, and it worked.
Yeah,
So I don't, not quite
it's
sure. Yeah.
it
So,
still works, so that they haven't ended the relationship yet between OSU and Pressbooks,
okay.
but we expect it will end at the end of the semester.
Yeah. Sounds fine.
So it's probably better to have the Texas A&M one in there because
Yeah.
that will be the future version.
Okay. Thank you.
You're
Appreciate
welcome.
the
Thanks.
update.
I'm glad I spent most of the morning doing that as opposed to getting ready for rounds. So, hey, here we are.
Good.
Okay. And I figure we will start with the dog and then move to the cat, if that's okay with everyone. I will do a little bit of an intro so that people um have the housekeeping discussion stuff. Okay, let's see. Just at 1 o'clock. Give a couple of seconds, minutes. Um, we are getting this loaded. Okay, everyone, welcome. Let's see. Yes, for some reason it won't let me change it back. Sometimes I can change my profile, Dr. Lynn, and sometimes it won't let me. And today is a Zoom mood where it's not letting me change my thing. This actually goes back to a JD joke a long time ago. So I blame JD for all this. Um, let's see who else here. Okay, oh wow, we got a lot of people. Welcome to Rounds for March. Happy St. Patrick's Day to all who celebrate. And we are hopefully, sorry, my something literally came to the door just right when there, and that was my dog barking. We have two cases today, so we're going to be a little bit quicker, I think, with the discussion, just because of the amount of content we want to get through. The dog case actually has two classic diseases, but they're two diseases combined into one dog. And so the main part will be discussing guidance on how to treat two very different disease processes. And then from there, we'll go on to the cat, which was biopsied a while ago, I think. And so we just want some more guidance or discussions for where to go next with this particular cat. Um, a couple housekeeping things. We have a lot of newbies on this session. So for those of you who join, this is very informal. Anybody who ever wants to present a biopsy case or even maybe a pathologist that has an interesting case that they would like to show as well. We are always looking for volunteers. And so just send me an email or a text, and we will get you on the list. We'll try to do it for the cases that have living patients. Will be triaged to the front of the list. And we usually get through one and a half. So today we'll be squishing to two cases. So always feel welcome to reach out and suggest a case for discussion. If you notice you have been kicked off the distribution list and you have not received an email, over the course of a month. Emails always go out every month near the beginning to ask for case requests or to tell you that case have already been requested. So if you haven't gotten any of those emails, then it's probably because Outlook decided to be stupid and to cut you off the list for no rhyme or reason. So always just reach out again, and we will put you back on the distribution list. There is really no reason behind how this happens. Sometimes Dr. Hokamp gets cut off the list, which is strange because she's the entire reason that this exists at Texas A&M, at its current state. Obviously, Dr. Lees is the reason it started at Texas A&M, but we don't know why sometimes people get kicked off the list. So never feel bad about asking, and we will make sure you get added back onto the list. If you happen to change locations and change practices, again, reach out, and then that way I can remove your old email address from the list. The list is quite large. And we like to invite anybody who is interested in kidney and urinary pathology. Um, Lastly, these are recorded. They do get uploaded to a location of which I always forget, but they are through the ACVNU site. Dr. Hokamp is probably going to put it onto the chat right now. And so if you ever want to look back at previous versions, or maybe you couldn't attend a session that you really were interested in, they are recorded, and we would invite you to watch those as well. There's some very old ones from way back when this was hosted at OSU. And so there's quite a variety of content on there for cases. Um, and if you guys have any questions or comments, please put them in the chat or raise your hand to speak up. We usually have a couple of people watching the chat to make sure that nothing goes overlooked. And with that, we will start with our first case, which is from Dr. Specht at Florida. And if you would like to share your screen or just, okay, perfect, awesome, great. I'm going to mute myself and probably take myself off camera for a moment.
Okay. If we have to get through two, I wasn't 100% sure how much information to put in, so I may have put a little bit too much of the pre, and I'm going to slide over a lot of that fast. But definitely, if anyone has questions, I'm more than happy to try to answer that. Having said that, the caveat to this case is that it was never actually my case primarily, either as my case or as the one I was specifically supervising. I have consulted throughout the case fairly heavily and tried to get a little bit more involved, but it wasn't my case. Some of this I don't have control over. But this was a case that presented to our ER on a Sunday. It had a 3-day history of basically some hyporexia, anorexia, and lethargy. A couple days before presentation, mildly hyporexic, then the next day completely anorexic. And the owner felt like there was more frequent urination. The history in the record doesn't make it clear whether that was plaquuria or polyuria, but there was a specific note that the dog was not perceived to be drinking more. On the day it came here, it also had gone to an urgent care in the morning, had vomited once, gotten some blood work, and the owner was very concerned about Sharpei fever, and because of the low albumin, they basically sent it straight over to UF. So past history, there is this report of an episode of Sharpei fever, very poorly documented in our discharges. It was about a year prior. It was presumptive. What we think we know is that the dog was febrile and may or may not have had swollen hocks, but we don't really have any blood work or anything from that time, and no real follow-up. Does have entropion surgery, atopy. It's been on a diet, and at one point had somewhat acute facial swelling for a Sharpei that they gave steroids and diphenhydramine for. This is a farm dog, horses and cats. Minimal exposure to those. They say up to date on vaccines, meds included, Apoquel for the atopy, heartworm preventatives regularly, and a joint supplement, but it's not stated what. When it had come in, obviously fair number of things here, but the thing they had focused on was the low albumin. Was interestingly hyponatremic, hypochloremic, and had some mild liver enzyme elevations. They on their CBC, this is where I think it was more interesting. White cell count of 36,000, 28,000 neutrophils, 6,000 monocytes. This was in-house. There was no slide review, but the white cell scatter plot definitely did suggest that there were either that monocyte count was potentially real or that there was some other cell there. And so we were taking it. A lot of times when we see that in-house, we basically say and we did in this case, basically say we don't know what to make of that until someone looks at a slide. But it does seem like there's a high count of something. Their initial physical, not febrile, was dehydrated, had some eye changes associated with persistent entropion, was reported to be tense on palpation, but a pain score was 0. And they did feel like there was some edema at the level of tibiotarsal joint. That was all we really had at that point. On ER, they had done an AFAST, no free fluid. They collected urine, which is great. They couldn't run it through ClinPath because it was Sunday night, so they saved it, but they got a specific gravity, which is something medicine always asks for and doesn't always get, 1060 at this point. PCV total solids, you can see 52 and 6. Blood pressures were relatively normal throughout the night. Lepto was negative on a witness, and a venous blood gas confirmed hyponatremia, hypochloremia. There was a mild metabolic acidosis with respiratory a compensatory response, and the hyperglycemia was present on that blood gas as well. They actually got transferred to what we call our hospital inpatient service, which is kind of an intern service for things that are sick, but it's not sure where they should go. Overnight, the dog had regurgitated, seemed polyuric actually by morning, didn't urinate for the first 8 hours and then became polyuric, was on some GI meds. They did give it a dose of Dex and diphenhydramine. It's not 100% clear why from the record. And in the morning with the polyuria and the weight gain of 5%, they decreased the fluids to what was considered to be a maintenance rate. Dog was bright, alert, and responsive. Heart rate, pulses, and respiratory rate basically went to normal by morning. It did now have a grade 2 murmur, but that seemed positional and didn't change for the rest of hospitalization. They essentially reran a chem, CBC, UA, UPC, and cortisol through our central lab. The hyperglycemia had resolved, ALT had resolved, ALP went up a little bit. Billy was just above our normal range at 0.6, and then I have some tracked values here. The most impressive things really were the UPC of 33 about, and then the white blood cell count of almost 60,000. Slide review through our ClinPath lab confirmed a monocyte count of 9,000. The client had been very concerned about amyloidosis and Sharpei fever. And the intern basically came to find the medicine consult, which was me in the morning, and said, hey, is this Sharpei fever? Can we transfer it? Basically. And my response was basically, yes, that is a worry in this dog, but I don't like that monocyte count. And this is more practical here at UF, but I did not want to take this one onto the medicine service immediately until we got a chance to consult with surgery as well, because I was worried this dog we needed to find where those monocytes were coming from and get it to surgery. So I made them consult with surgery, who basically said, why are you talking to us? You don't have a surgical disease. To paraphrase, didn't really find anything interesting. And we checked on the eyes, which were still entropion. The next day, they did get it to imaging. It had been full the day before, and the dog was stable, so it wasn't an emergency, but basically had full splenic thrombosis, still didn't have any perceived overt abdominal pain. Thoracic rads were normal. I was basically telling them to look for some place for necrosis. And this is really the main thing they found. Going back again, no pain score of 0.4, just a mildly tense abdominal palpation. Our ultrasound did find this thrombosis. So we went back to talk to surgery about this. This was essentially a big discussion. And I think for internists and surgeons, this is always an issue, is what do you do with splenic thrombosis? In my experience at least, Sometimes it's very clear that they're painful and sick, and sometimes it's really tricky to figure out if splenic thrombosis is doing anything. But given the monocytes and the lack of anything else, I still wanted this dog to go to surgery before it came to medicine. For this, just to be sure. They wanted a few more things, so we did a CT, which confirmed those findings. So there's a big clot in the near where this splenic vein enters the portal. It blocks the whole splenic vein. So if we scroll through this CT, it's a huge, enormous clot. Cytology, surprisingly, from the spleen was pretty boring. They did not see evidence of necrosis. The liver, they did not see anything particularly interesting. And because of the clot, they tried to run a VCM, which is a viscoelastic coagulation test like a TEG. They could not get it to work that day, so they settled for a coagulation panel by itself, which you can see high D-dimers, high fibrinogen, and slightly prolonged PT-PTT, so a little bit of an interesting mixed pattern there. Ultimately, we sent this dog for splenectomy to get liver biopsies and cultures, as well as to get kidney biopsies to send in, and then volunteered to take the case as soon as it came out of surgery to follow up on the proteinuria and the rest of the disease. The kidney biopsies, it was an open abdomen to do the splenectomy, but the biopsies were collected as true cut type needle biopsies. And I had volunteered, this still wasn't my case, but I essentially went in after hours to collect the biopsies after they got them, put them on the slides, cut them up, and send them in.
Yeah, that sounds great. Yeah, we'll go to the pathology. I mean, so
Sounds
dog
good.
recovered well. Dog is still with us, correct?
Dog is doing fantastic.
Okay. So I'll show you the cool diseases because it has two diseases. So everybody put your thinking cap on, and those of you who are near the chat function of your thing, based on signalment, what is your top differential diagnoses? Please put it in the chat. Anybody who is available to actually type in their computer. I know some people watch this while they're driving their car. Um, okay, let me make sure I'm getting my pictures up. And okay, so and thank you so much for being able to process the tissue because they were gorgeous biopsies. And so sometimes when we get these and they have been done intra-op, they can be a little bit difficult to visualize because, or they don't always have a lot of cortex in them, I guess I should say. So we have great biopsy cores. Do we have anybody in the chat? Okay, great. Ooh, amyloid and vasculitis. Not, why not both? Yes, let's do some multiple differentials. Okay, so it's a Sharpei that's on our differential. I will say I looked at this and I didn't know it was a Sharpei, and I said, I wonder if this has amyloid. And then I looked and I said, oh, it's a Sharpei. Well, that's exciting. So that helps me with my differential. And that was based just on the H&E, and that's because I see a lot of glomeruli. Pathologists who do not see a lot of glomeruli might look at some of these glomeruli and not think too much about them. Hopefully, Dr. Hokamp, you can give me a thumbs up that we're seeing biopsy.
Yep.
Cool. Okay. So we've got some glomeruli, and we have just this hint of a little bit of mesangial expansion. Now the H&E is not always is everything's going to be pink with an H&E, so it's not going to be that helpful for this disease. But I do want to back out for just a moment and give you guys this impression about how clean and non-inflamed these kidneys are. There's not a lot of fibrosis. There's not hardly any inflammation. We just have great renal cortex. These tubules are back to back. They're immediately adjacent to one another. They only have peritubular capillaries in between them. And then we have many scattered glomeruli. And so I'm just going to go into the PAS. I'm not going to keep loading these. So the PAS is a good stain for us to differentiate where capillary and mesangium is versus the lumens of the capillaries and also versus podocyte cytoplasm. And for most of the mesangium and GBM, it should be this kind of bright pink color, which it is. So that's very helpful for that. We have a little bit of circulating inflammatory cells, but we do know he has a high white cell count. Not that there's ever been any kind of correlation between, white cell count and how many inflammatories you're allowed to have. But overall, we have a little bit of mesangial expansion, but not a significant amount. The GBMs themselves, the capillary walls, are of fairly normal thickness. You can use our tubular-based membrane of a healthy tubule as our positive control, and so, or I guess our normal control. And so they're about the same thickness. But we have a little bit of a hint of expansion within these areas. And this has actually a little bit of kerrectic debris, which I don't, might be because of the inflammatory process that's going on. The fact that there's, a high white count and there's thrombosis of the spleen. The Jones is where it gets a little, sorry, the trichome is where it gets a little bit interesting. Again, we're looking at this hint of this kind of like hazy, very mild expansion of the mesangium. But again, it's not entire effacement of capillary walls or capillary lumens. It's just this mild amount of increased blue color because the mesangium should be blue. It's got a lot of collagen in it. So a little bit of increased matrix. But for people who look at a lot of trichromes, and this is a little bit because I think I'm on super high mag, I think I'm over magnifying with 80. But hopefully you can see my cursor is pointing to some red dots right around here. Dr. Hokamp, is my cursor working? Yes. Okay. Thank you. So there's some red dots on the trichrome, and again, this is always a little like weird, faint evidence of maybe another disease process that's going on. But usually, if we're going to call it on histology, we want to see much more significant red dots. And then we'll go to the Jones. The Jones is very helpful as well. And I think this is kind of the one where whenever we see a sample from a Sharpei, we go ahead and run a Conga Red just in case. So we don't always run a Conga Red on all of our renal biopsy patients. But for breeds that have an increased incidence of amyloid, we almost always request it. And so there can be a little bit of a normal Jones should be dark black, should be like dark. I mean, black is black, right? So it should be that color should be your mesangium. But when we're looking at this particular Jones, we're getting this kind of hazy gray material in the mesangial zones, which is not typical. So that means something's there that shouldn't be there. And then along with uh, our red nodules that were kind of hanging out in the trichrome, we're starting to see a tiny bit of remodeling of the capillary walls on the Jones stain. So the mesangial expansion by our various colored matrix is one disease, and that's going to go down the amyloidosis road. But this other disease with these small red nodules and this tiny bit of remodeling of the GBM is going to go to our second disease process. So we have two different diseases. I've only seen them once overlap in one previous case, so this is the second case I've ever seen it overlap. But hopefully you guys can see these tiny little projections here. They're going from the GBM out towards urinary space. And then you can also see these tiny little circles, and each one of these circles is a little bit of probably membrane that's right around what are going to end up being deposits. I don't really need to hide it from you because we're going to see the IF really soon. So, but back to our original suspected diagnosis of amyloidosis, we ran a Conga Red, and Conga Red is weird because it's not red, it's peach. And the other thing we always have to read through is looking for the fact that there's already collagen. Collagen already kind of stains it a little bit peach. So looking at the Conga Red, it wasn't super exciting. It was all of this peach stuff here is probably more red blood cells because it looks like some of them are in capillary loops. But we did ask Dr. Hokamp to go in and do the professional look at it with a polarizer, and you have to go into a dark room. And you need to turn out all the lights in the room. And you need to, oh, hold on one second. I need to figure out where I put it on this picture. One second. Hold on. I downloaded it. So you have to turn out all the lights in the room. You have to have your polarizer. You have to be able to go back and forth in your with the polarizer because it's going to go kind of up and down. And I'm just going to show it this way because this is a little bit the easiest way. And there's two pictures that she was able to take for us. And now I'm going to share that part of the screen. Okay, this is just from the report. So uh, this tiny bit of apple green material. And again, it's actually sometimes usually like a little bit more like yellow. It doesn't even look like it's true bright apple green. But that is the color that amyloid will show. And you can see that it's in this one tiny segment of the glomerulus. It's probably up here in the glomerulus, but this rest of the region of the glomerulus does not have the birefringence that is the apple green birefringence we see with polarized light. When collagen is viewed with polarized light, it's this pale white color, maybe like almost like white blue. So that's collagen, and this here is apple green birefringent. So we, even with just this, here's our second glomerulus that she was able to take a picture of. We have very faint amounts of amyloid based on the Congo red. So, based on just histology, we were pretty confident that it was amyloidosis. And we discussed this case. It was a little bit weak, and so we went ahead and not weak. Let me say that. It's like it was mild amyloidosis. So we're like, let's go ahead and make sure we do all the extra steps for this case. Plus, we had this extra history, and we were talking with Dr. Specht about it, and he said, yeah, let's go ahead and do everything. So then we have one diagnosis. You guys have I'm beating this into the ground. We have one diagnosis, but now we're going to do the immunofluorescence and show you what that looks like. So all of you guys who have evidence of or have access to your chat, what am I hinting at when I'm talking about these red nodular deposits, and I'm literally just talking about deposits? What type of disease am I mentioning as I bring up this next set of photos for you guys to look at? What else are you suspected is my second diagnosis for this case. I have, okay, hold on. Opening these, and then I'm going to show it to you guys. Do we have anything in the chat? Anybody? Okay. Okay, great. Okay. We have two internists that answered the question. I'm so excited. It wasn't even just relying on pathologists to answer these questions. That's exciting. Okay, so now we're concerned that there's something else going on in this dog because of the tiny faint amount of remodeling that we saw on the Jones stain and the occasional stretches of capillary loops that had small red nodules. Okay, so here is our IgG. And you can see each one of these little red dots is an immune complex deposit. And they are quite prominent all along the capillary walls, and they also kind of go down towards the mesangial zones. Here's another IgG. This is gorgeous for IgG. We normally actually never see it this strong in comparison to the tubular nutritium. Usually we see them kind of like almost somewhat similar intensity. And so the tubular nutritium's background, but the fact that this is taking up every single little fluorophore and binding to the glomeruli is quite impressive. It also has good lambda light chain as well. The IgA was negative. It actually was fairly weak with C3, which I think is interesting. And I'm not entirely sure what that means other than maybe the complement system hadn't yet been activated yet, or maybe this dog doesn't have a lot of complement system protein in it. But we have prominent IgG based on immunofluorescence. And we'll go back to one more thing. Okay, we're going to go back to here, which is the report, so I can just show you the images from the EM. So let me make this bigger.
And Rachel,
When we're looking at immune complex disease, the immunofluorescence tells us there's immunoglobulins there, but the second piece of evidence for immune complex disease is looking at the electron microscopy. And so each one of these little densities that I'm circling with my arrow is an immune complex deposit, and they are on the abluminal, subepithelial, subpodocytic portion of the capillary loop. So this is consistent with a membranous pattern. And then you can see that the capillary lumens themselves actually don't have a lot of hypercellularity, so that's why we call it membranous. It's just the GBM that's affected. It's not hypercellularity within the glomerular capillary lumens, but multiple different capillary loops have these electron densities. And then hopefully, I'm going to zoom in just a little bit more. Hold on, see if I can do this one more second. Um, so the silver stain, which we were looking at with those spikes and those little holes, that's this tiny faint amount of gray, and then the slightly darker gray is the deposit. So the deposit is slightly darker than the GBM and the capillary remodeling. So that is what we saw on the Jones is the slight gray, and on the trichrome, which was red, ends up being this darker density here. So we have two diagnoses for this patient, and we diagnose early membranous, or I think membranous, and early amyloidosis or mild amyloidosis. And the tubular incision was actually pretty darn good, so that had a good prognosis from our perspective for the patient. And we weren't really sure how to advise based on treatment because we want to try to make sure that no more deposits are getting deposited or added to the GBM. But now that we've removed the spleen, maybe we've already kind of stopped that possibility. So with
Rachel?
that, would you like to address how the patient's doing now?
Sure. Let's see. So I'm just going to share this one more time. Um, so yeah, we the timing of this was fascinating. So dog recovered great, started eating immediately after surgery. Essentially was ready to go home by the following day. So it came to us, stayed a day, and then went home. Us being the other service, not mine. At this point, being immediately one of our big worries on this dog was it was so proteinuric, already thrombotic. We had some worries about taking it to surgery in the first place, but we felt like my feeling was we had to do it. But there was a lot of debate about that. And then there was a lot of debate of if we take a dog to surgery, this was a Sharpei. So we thought we were going to want to start colchicine. But the worry on that would be when do you start it? Essentially our debates. When do we start that? Given surgery. So I'd love to hear thoughts, but I only have one experience with that, which I'll just share, which was a peg tube that I removed on a dog once, and the hole didn't close for about 5 days, and I couldn't figure out why. And then we realized the dog was on colchicine for liver disease. We stopped it, and the hole closed in a couple days. So that's my brief anecdotal experience that colchicine can affect healing, and so it terrified me a little to start this dog too fast on it. Fair or not. And then we also were worried about if this was amyloid, whether other standard therapy would be appropriate. And we didn't have this information about immune mediated, although it was a possibility still. Anyway, by the time he came back for his 1 week recheck, doing great clinically off most of his meds, the owners hadn't actually started the colchicine yet and had only been on telmisartan for 2 days. And this was our albumin was up to 2.5. Our UPC was down to 1.1 from 33. And unfortunately, the CBC clotted, so I don't know what this was a tech appointment. So it came in, had blood and urine drawn, and then got sent out the door. But we have this dramatic reduction in UPC. And we had this information before we got the information about the immune complex disease. So clinically, what we decided at that point was we were going to essentially hold off and plus minus things because the biopsies came back a little bit later. And so we basically then said, well, let's get him back real fast, like another week, and essentially plus minus starting immunosuppressives depending on the UPC trend. But it took them, they didn't actually come back right away, and they went to their referring vet next. And this is where it gets disappointing as I still don't have all of the information. So I don't know why we still don't have an actual CBC recheck. We do have a blood smear that they looked at and said looked normal in terms of white cell count. But I have not gotten to see that. So this dog is down to a UPC of 0.4. And it is not on anything to really treat the proteinuria at this point. We do have a debate. I think after a long discussion with the owner, they had decided to see how the dog tolerated colchicine just because of the little bit of amyloid there and because of the history of maybe having it was 2 years old. It's a Sharpei. There is some amyloid there. It's possible that that's not breed related, but with the history of the fever episode at a year and now this, we were going to see how that goes and then still be rechecking. But we're still really uncertain about this case given the biopsies, but also the clinical response. But it kind of fits the whole, if you have something, treat that first and see what happens to your UPC.
Yeah, it's very interesting. And so when I said we've only seen this once before, I think the only thing that comes to my mind was we had a membranous case. I'm pretty sure it was membranous, not membranous. It was an immune complex GN, and I was scoping it just to verify the presence of immune complexes, and I surprisingly found amyloid, and we did not suspect it based on histology at all. I don't think it was a breed that was predisposed to it, and I'm pretty sure it was an NC State case. But I was just, scoping for immune complexes, and I was like, oh wow, there's a whole bunch of amyloid in the glomerulus. I have occasionally seen cases that were surprise amyloidosis at autopsy, and only a couple of glomeruli were affected, as opposed to every single glomerulus in the kidney, which again usually goes against most of our rules. We usually think that amyloid should hit every single glomerulus. So, I guess in the interest of time, the concept of, I mean, I do know telmisartan has in some amyloidotic patients has dramatically reduced the UPC. That we've seen that from the Braccio Italiano dogs. Um, and I think there is actually a lot of pathophysiologic ways that telmisartan will interact with production of serum amyloid A, which I was unaware of until that was kind of investigated. I mean, but the UPC now is zero point 0.4. Um, and what I see Dr. Lees has popped up, so I'm going to see what he says as a clinician.
I'm suspicious that the dog's proteinuria is really the membranous disease. And we don't know what caused the membranous disease, but in people, a third of them spontaneously improve membranous. And of course, they now know there's a lot of different causes of membranous pattern, and even different antigens and things. And so I'm kind of suspicious that the proteinuria has resolved mainly because membranous disease has decided to subside. Whether that's connected to removal of the spleen and I'm not sure. Did the spleen is that where all the monocytes were going or coming from, or are we still, have an unexplained monocytosis? So
yeah, the histopath so the cytology of the spleen was surprisingly normal. But the histopath was necrotic. There was just necrosis in it. So I'm assuming that's where they were going. I wish I had a count to actually say that it was all the way down to a normal count.
Well, but that's fine. The other piece of that, though, is the thrombosis probably as a result of the proteinuria, and so you might have to have the glomerular disease enough to cause a substantial proteinuria and make the dog thrombotic before you get any necrosis of the spleen. It's sort of which is the chicken and which is the egg here, but backing off and accepting that we don't know answers to things. The best thing to do is let well enough alone until the dog makes us do something. And with the UPC dropping to basically normal. I mean, I've said before, not in this group particularly, but if I was a dog and I had to have glomerular disease, I would pick membranous because that's the one we have sometimes made completely well with treatment.
And it would be there. We have seen occasionally masses and spleens that are usually more of the kind of how do I want to say it? Follicular lymphomas. They're not like a really bad splenic lymphoma, but a follicular type lymphoma. And they often, so when we get biopsies and they also have splenectomy, that is usually the diagnosis, because usually a splenectomy is for a mass and not because it's infarcted. And sometimes the proteinuria will resolve just removal of the spleen. And so we haven't published it yet, but there is a correlation between cancer and membranous in humans. We looked to see all cancers way back when Dr. Harris was visiting us at OSU, and we did not see a relationship between all cancers and membranous. But there have been a few like cases that stick out in my head, which were splenectomies. They had follicular lymphomas. The splenectomy led to resolution of the proteinuria, and also the diagnosis was immune complex disease. So we probably need to maybe shoehorn that project so it's really only about those two types to see uh, uh, to see if maybe we could actually find a relationship. When we looked at all cancers, it really wasn't a relationship between cancer and membranous. One more project to add to our list. And yes, and Dr. Hokamp is talking about an SDS page. Maybe it would be great if the patient does come back to Florida, like if you guys could get a urine and send a repeat SDS page, so she can compare the proteinuric one that was severely proteinuric to a repeat, and see if the bands change. And I think that would be done at no charge, Dr. Hokamp, correct? Since it's a follow-up.
Correct. Are you able to hear me now? My microphone's
Yes.
finally working. Okay, great.
Yes.
Yes.
Okay. So
It's
I mean,
not a massively impressive SDS, but I do like my follow-ups.
okay. And then, so everybody that's a clinician on this discussion thinks leave well enough alone at this point and monitor. Dr. Syme, I know you're mentioning you're popping up as well, and staff are.
Well, I'm not sure that I mean, I think with that initial UPC, I'd have been inclined to treat it then as it sounds like Andrew was inclined to treat it at the same time. But having had the UPC go down to 0.4, well, let's see if it continues to go down. And if you introduce something now, you're not going to know whether it's continuing to recover or if it's the medication. And I don't think there's any desperate imperative to treat at this point, given how much improvement you've seen spontaneously or related to removing the spleen or for whatever reason.
Well, we might consider the removal of the spleen a treatment, and
Yeah.
and ask the question: has that treatment been sufficient or not? I'll throw in also early on we had a case. I think it was from the University of California. It's a group down in San Diego that I didn't. I'm the guy looking at it at this point. It's so long ago. I didn't recognize that there was amyloid until after we did the EM, found a little bit of amyloid, and I went back and scrubbed it and looked at it and looked at it, and finally found enough to have the vaguest suspicion on the basis of the light microscopy after looking to know that it was there. But and so that was in my early experience was the mildest case I'd ever seen, but it also rapidly progressed, as I recall. So it wasn't but a few months, less than a year later, it was um, end stage, if you will. And so, and I'll let other people. I have very little personal experience treating amyloid in any breed, much less Sharpeis with colchicine, and absent any personal experience with it, I really don't know how effective we really think it is, or is it just something we give because we don't know anything else to do?
That on that note, as we're moving on to the next case, we are trying to look for other proteins in humans. There's multiple different proteins that can become amyloid fibrils. So we're hopefully starting a project with that soon, and to see if we can find other, especially with the familial amyloidoses. But we'll never know until we keep looking for these types of proteins. Um, we don't really have as much targeted therapy as they have in humans. Even in humans, they do have a targeted therapy against serum amyloid A, and we are not allowed, when we have contacted the drug company, we are not allowed to use it. So that has been a while ago, so maybe we could reach out again. But the the tubular nutrition of this dog looks great, which is why he's not azotemic. But and I'm not sure how long or how often episodes of inflammation will cause more amyloid to be deposited in these glomeruli. If ever they want to rebiopsy, that would be a great case for us to have additional follow-up for tissue. Or in the event the dog does progress and needs to be euthanized, we could get follow-up tissue post-mortem because we don't have a lot of serial progression studies for amyloidosis. So that would be very helpful for us. We've had a lot of cases that were severe and have lasted like over a year of severe amyloidosis. They've lasted over a year, survived over a year, I guess I should say is the right word, survived for more than a year with bad amyloidosis. And we've had cases like Dr. Lees mentions where it's very, very mild and it progresses rapidly, and we don't know the difference, who is going to do what. So all even though it's a classic disease, which a lot of pathologists know about, and we've been really good at diagnosing for the past 30 to 40 to 50 years. Did you guys know that the IVRPS is 20 years old? So, if so we've known about this for a long time, but we still don't have a lot of information about how it progresses and which cases might progress more rapidly than others. So we still would love to collect additional material for this. And then as we're
Rachel,
getting, yes,
sorry, for the follow-up biopsy, necropsy,
yes.
no charge on those, right? Or how do we
Yeah, I would assume it would be something that we would just probably do histology for. I don't think we would
at
need
least
to.
start
But
with
yes,
that?
collecting all the samples would be great. Collecting all the samples if that happens, and then it would send to us, and then we kind of decide what we would do. Because even just having a congruent on a single sample might give us more information about how it progressed. So,
And Schropp has a question.
what was it? What did you end up thinking about the laser capture? Uh, oh, that's a different case, Dr. Shropshire.
That's what I
That's a
was
JD
thinking, that it
case.
was a different case.
Oh yeah,
So
no, I know it's different. I just was wondering, do you think that whole concept is worth it?
So to investigate what material is in the amyloid or is making the amyloid, we're kind of attempting a similar process, hopefully at Texas A&M if we get everything funded. Um, for amyloid A stuff, you shouldn't really need to do LCM in order to get the glomeruli. You shouldn't really have amyloid A in your kidney at all, so that should
Yeah.
be fine for just regular tissue block digestion. The only times you would really need to say, is it truly glomerular, is something that would be a native protein. So you know that you're harvesting just the area that has amyloid. There's probably a few other techniques that would be a little bit more sensitive these days to do that. But I think even starting with just protein digestion of the entire tissue would be helpful.
Okay.
But yeah, so what Dr. Schrapp is talking about is at Mayo Clinic, or sorry, in humans, we get an amyloid and it's like maybe even a familial amyloid, and it's not one of these reactive inflammatory types amyloids. And it's not, and also doesn't have lymphoma, so we know it's not light chain amyloid. Or a myeloproliferative disease. So we've ruled out light chain amyloidosis. We have some other atypical amyloidosis. Every single one of those blocks at OSU gets shipped up to Mayo Clinic, and they digest it and they find out what the base protein is to make the amyloid fibril. They do laser capture microdissection to just hone in on the gloms. But they'll be able to say, and oftentimes they come back and say it's just serum amyloid A. So they can find out which kind of protein would be the basis. Um, we have done laser capture microdissection on two samples. One has been a whole bunch of groups from pronghorn antelope from the Columbus Zoo that had a bunch of amyloidosis, and they were all related or semi-related because they're zoo animals. And then we also done mass spec on an amyloid case that had thrombosis and um, uh, widespread disease from multiple different disease problems. And because we were publishing it, we did mass spec on that dog as well. So it will be something that should both of those scenarios were serum amyloid A. So Okay, Dr. Fitzgerald, are you ready to mention or the pathology will be minor. I'm just going to show images from the report, so don't worry about me rambling.
Okay, yeah, let me share my screen. Okay, can you see my screen okay?
Yes, we can.
Okay, perfect. I'm Allie. I'm one of the ACVNU residents at Friendship, so I'll be talking about me too. Okay, so me too, 3-year-old male neutered tabby cat that presented in the fall last year for lethargy, dyspnea.
The slides aren't advancing, so I'm not sure if you have it because we see it like
Oh,
the slide view and not the presenter view,
hmm.
unless
Yeah,
your
it says my
Bluetooth.
screen is paused. That's weird. Let's see. So you can see this fine?
You're
Oh,
actually not sharing right now.
Now it's not sharing. It's starting to
okay.
share, and it looks like that when you're making the slides, though.
Yeah, it's like the draft version.
Okay.
You might be able to just scroll down and just go through those draft slides. There it
Now I can
goes.
see it. Perfect.
It's all okay, perfect. And it's advancing fine, yeah. Okay. So presented in the fall last year for lethargy, dyspnea, and then bicavitary effusion. They initially thought left-sided heart failure, performed a thoracocentesis, which revealed a pure transidate on fluid analysis. They also did an echocardiogram with the RDBM, which showed normal cardiac structure and function. Triple snap was negative, and then presented to Friendship early October for just ongoing hyperexia and lethargy. He was mildly tachypnic on their initial exam. They noted mild distension of his abdomen, but otherwise normal physical exam. So he was with the critical care service before we got involved for several days. So he had a full body CT. He had mRNA of looking for FIP, culture of his pleural effusion, all of that. Pretty showed like pretty non-specific stuff. So some subcu edema, pancreatic edema, um, and then continued diagnostics. So ultrasound showed some segmental portal hypertension, renomegaly with loss of corticomedullary distinction, peritoneal effusion, lymphadenopathy, and pancreatic edema. On physical exam, when we took over, the only other finding was peripheral edema in all 4 limbs. They also did a FNA of one of the intra-abdominal lymph nodes that came back as normal. We consulted on the case the day before it came to us and recommended doing a urinalysis, which showed concentrated urine, 4 plus protein, mild pyuria, and scant hematuria with occasional granular casts. I looked at his urine on in-house cytology, which was pretty quiet. And then we got a UPC back several days later as a send out. So UPC was 8.3, and then these are his serial labs over time. So had moderate asthenia with a creat up to 3.2. Albumin was 1.7. He had a non-regenerative anemia with a crit of 23. And then his azotemia had improved some. And then in terms of treatments, we suspected nephrotic syndrome for him. The other thing on his labs too is his cholesterol was high at 480 on intake. Um, so we decided to stabilize him before renal biopsy. Obviously, he was quite anemic too. So um, got him feeling better at home. So we started steroids with an induction dose of 0.4 mg per kg of DexSP, and then for 1 dose, then tapered him to 0.28 Q24. We stopped his fluids. We gave him Spiro in hospital at a mg per kg twice daily, and discharged him with prednisolone, spironolactone, and then Mirtaz. And then saw him back 3 days after discharge. I also did a thoracocentesis before leaving. He was still a little bit tachypnic and had progressive effusion despite Spiro. Did really well at home. Effusion was really scant on my recheck mid-October. And so then we biopsied him in November, where his crit had come up to like about 35% at that point. And then I can go through his update after we go through the path.
Yeah, so we'll show actually I don't need, okay, we'll show some images from the case. So we had two cores. There were 11 glomeruli. In cats, oftentimes we get like a little bit smaller of cortex, smaller amount of cortex. And the main thing that is going to be easy to see on all four of these images is if you're looking at kind of like the 6 to 7 p.m. Region of the glomerular tuft on every single one, you're going to see that the glomerular capillary loops are not open. They're actually uh, effaced by additional matrix. So the matrix is collagenous based, which is why the trichrome is blue. And then you have adhesions between the glomerular tuft and Bowman's capsule. So those are synechia, and that is prominent or seen in a lot of the glomeruli. This particular glomerulus probably just has the adhesion part and maybe a little bit of sclerosis. Um, so, uh, but those are kind of the main features we're seeing on histology. The tubular system has a little bit of inflammation, and a little bit of tubular degeneration, which is typical that we almost see in every single cat with or without glomerular disease. The So when we see this kind of non-specific adhesions, a little bit of sclerosis, we need the additional diagnostics in order to figure out, is this all something that's kind of smoldering from immune complex disease, or is this a primary, only sclerosis pattern, just podocyte injury, just sclerosis pattern? And so we do the additional diagnostics for those. And so the EM is very helpful because we're not seeing any of those electron dense deposits like we saw in the Sharpei. So we're not seeing any of those dark black foci along the capillary loops. And we're not seeing any kind of remodeling like we saw in the Sharpei as well. Um, the podocytes themselves, a little bit of injury. We have some regions which are foot process effacement. So all the tiny little foot processes in this region are fused together. The other thing that podocytes do when they're angry is they have little tiny microvillus transformations. So all these little tiny tendrils near the bottom of the image is microvillus transformation of the cytoplasm. Again, just shows us podocytes degenerating. It doesn't tell us why. But we can rule out that there is immune complex disease because we're not seeing any of those dark black foci that we had seen with like we had seen in the Sharpei in the previous case. So foot process effacement, podocyte injury, microvillus transformation, and I think this is mesangial zone. I'll have to look at it again. I think that's a mesangial cell that has some material inside of its cytoplasm. And then the IF didn't even take pictures because it was so boring. So negative for our immunofluorescence, especially when we're talking about our IgG. Sometimes you'll see a little bit of haziness just as the non-specific staining. We always report it, even though it's kind of a non-specific pattern. But when it's weak or trace and it's this blush labeling, we are not excited that it's we believe that's a non-specific pattern. And the lambda always almost seems to follow the IgG, but the IgG is our more important one, and it's negative. So we diagnosed, segmental glomerulosclerosis, and then some tubular degeneration and atrophy that was kind of going on in the background. And we said that we had no evidence that there's an immune complex process going on. This seems to be a podocyte problem, a sclerosis problem. And that was our consensus diagnosis. And so let's talk about how he's doing now.
Yeah, so we talked about it as a group and thought, well, maybe we should manage him like a primary FSGS because he's never been hypertensive and doesn't have like a reason to really have sclerosis. So we tapered his steroids back in December to, let me share my screen so I can show the labs as well. So yeah, tapered him from about 2.5 mg per kg per day of prednisolone to 1.5 mg per
It's
kg
not
per day.
sharing.
Oh, geez. Let's see. Okay, can you see it now?
Yes.
Okay,
Yes.
perfect. Okay, so in December, so just as a reminder with his last creat was 1.7, BUN 21. And his UPC, like day of biopsy, was 1.5. And then we tapered his steroid from 2.5 to 1.5 mg per kg per day. And his UPC at that point, pre-taper, was 0.8. So happy that his kidney values have trended down, his albumin's improving, UPC improving, but we were just kind of discussing it's such a robust response. Like, should we start cyclosporin, which is what we ended up doing. And so on the January visit, started cyclosporin at 5 mg per kg once daily, and then tapered his steroid to just like anti-inflammatory, like half a mg per kg per day. He's clinically has been doing really well this whole time, but I thought it'd just kind of be an interesting discussion to kind of talk about his management. And I think at this point, like I just saw him this past week and his UPC's continuing to improve after being on cyclosporin for about a month. He's also on telmisartan at a mg per kg per day. But I think the question is, like, does he need a bit more time on cyclosporin? I was going to recheck his urine in about a month. And if we're not seeing any more improvement in his UPC, I was going to increase his telmisartan.
This is a good question for the clinicians, and I know I'm not sure if every people we have still have a pretty good number of people here. So as people want to speak up that treat a lot more cats, I will say that we know that there's sclerosis, so oftentimes we expect that there's going to be some residual proteinuria in those cases. It's going to be hard to get back to completely normal, from my perspective. So I would think that as long as it's trending down and kind of staying in the less than 2, that might be what his best UPC to offer. Dr. Syme, you treat a lot of cats with kidney disease. She might not be available. Oh, there she is.
Yeah, I am. But I've been flitting in and out, so I may not have given it full attention. But I'm just looking at so the question was what? Sorry.
Just how go ahead. You can speak, Dr. Fitzgerald. Sorry.
So it's really just about like his current management strategy. So we're suspecting, could he have like an immune responsive component to his underlying kidney disease? Treating him as like a primary FSGS as they would like in pediatrics is a lot of what we were talking about as we were going through this case as a team. So like continuing him on cyclosporin to see if at this point he's been on it for about a month, his UPC has gone from 1.6 to 1. He's non-azedemic, clinically doing well. Could we see more improvement maybe with his UPC as he's been on it for a little bit longer? So my plan at this point was to check a UPC in about a month. And if his UPC is still static or not improving further, then increasing his dose of telmisartan.
But was the telmisartan introduced at the same time, so the response that you could be seeing could be due to the telmisartan rather than the cyclosporin?
No, his telmisartan was introduced post biopsy, like a week post biopsy, so like early December.
Right. So I mean, I guess it sort of hasn't really changed, has it? It's just always about the same. So I don't know. It's well tolerated. So whether you continue both or you continue just the telmisartan and wait and see what happens. I think I could argue it both ways.
Yeah, and I think it's hard to know, like to really prove in this case that like the disease process just was improving on its own, or if it truly had like a immune mediated component to it. I think that's also a bit tough. But I guess like for me, it's just interesting the cat came in so sick, nephrotic. Like, what's the chance that this cat, I guess, just got better on its own? you know? It's just kind of interesting to think about.
Yeah, but kind of similar to what George was saying in the previous case that we were discussing with the membranous. I had one cat during my PhD that presented in nephrotic syndrome, and when I first saw it before, because of the charity clinic in which we see it, I wasn't able to immediately put it on any medication, and I changed it to a renal diet, reduced the protein content, and actually that cat became non-nephrotic just in either spontaneously or just in response to the change in diet. And I did subsequently, well, it predated telmisartan, so I did subsequently put it on benazepril, but that cat, which I always presumed had membranous, but I don't think we ever got a biopsy from it. But that cat definitely went from presenting as a nephrotic blob to completely sort of normal in outward appearance, still substantially proteinuric, but albumin returned to normal even before I introduced any pharmacologic therapy.
Interesting.
And I think we are recognizing a group of cats that have kind of tubular injury and podocyte injury at the same time. And some of them have been biopsied immediately when that initially starts, and so we get to see both of them at the same time, and then and they're proteinuric at that point. We've had a few where they were proteinuric, and like your cat, it was biopsied by the time the UPC went from 8 to 1, and it was 1.5 when I was biopsied. So we don't really know what was going on when the UPC was 8.
Right.
We recently had a case with Dr. Amerman that we were looking at, which had really bad UPC. By the time it was biopsied, it was only 0.4 or something. We could still see podocyte injury, but we at least could say there's no immune deposits. There's nothing in there that's saying this is immune complexes that are being deposited. Now, there is a whole discussion about how much does the immune system play in the development of primary FSGS. And so that FSGS itself has its own two types of disease processes, or I guess pathogeneses, maybe even 3 or 4 different kinds of pathogeneses for FSGS. So making sure the immune system is kept quiet can help FSGS cases. In humans, most FSGS cases, they'll start with steroids, and then you follow a track of your steroid responsive FSGS or your steroid non-responsive FSGS, or maybe your post-steroid relapsing FSGS. So a lot of these things, the immune system can play a role in some types of FSGS, and so I think keeping the immune system quiet could possibly help. It would be really interesting to see what happens when you take him off the cyclosporin.
Right.
I mean, we don't want him to be an experiment, but like it would be very interesting to see, like, is that going to then make everything kind of flare again and then damage the podocytes from that? I know we're coming up on time. Actually, we're 5 minutes over. I want to apologize for trying to squish 2 cases that were incredibly interesting into 1 hour. It was my fault. Do not blame the presenters. It was me thinking that we could do 2 at once. But they were both incredibly interesting cases. And I wanted to make sure we were able to at least provide some treatment guidance, or maybe just all of us being, gee whiz, I don't know, make you feel a little bit better. Like we all don't know how to do this. So even that might give you a bit of confidence that it's not like you're doing anything wrong. We're all kind of at the forefront of management of these cases. We used to be at the forefront of diagnosing for a long time. And now we're trying to figure out how do we make these cohorts to say this one's going to behave that way with this therapy.
So let me, with excuse me, with regard to the cat, we tend to use focal segmental FSGS like it's a disease diagnosis, and that is how it's come to us from human medicine. That you go to human renal rounds and stuff like this, and they talk about that term as if it's a disease like diabetes mellitus or something. But what we're really talking about is just a pattern of injury, and that the target cell for the injury is the podocyte. And now, if we really want to back up and accept that cats are not dogs and cats and dogs are not people and whatnot, what we don't know is what really is the most common cause or the most common set of 4 or 5 causes of podocyte injuries in cats. And are they endogenous or are they exogenous? And if they happen, do they happen continuously, or is it like an episode that he was exposed to and his podocytes got all hurt and mad and he became nephrotic? But, like spraining my ankle, after a while, it doesn't feel so bad and I can walk on it and I'm back to, okay. Or is it something that will only subside if we suppress the production of some immune factor that is circulating around and poisoning them internally? And the fact is, we don't know. And the conservative in me is that if we treat everything with a dab of owl urine behind the ear, and some of them get better, we think the owl urine is pretty effective, and then if it's a dose that the people have to give every day and it doesn't respond, we just blame the clients for not treating it right. So um, I think we just don't know in this cat whether the podocytes got injured in some way that is already history, and we're watching the aftermath of that.
Yes, and I totally agree, and I think that is these are future directions as we start to accumulate more and more of these cases. We're getting so many more cat kidney biopsies these days, guys. Like we used to get like maybe 10 a year. Now we're getting a lot more. Um, so we are slowly amassing these cases like we are getting the classics for dogs. And I think also I added on there maybe doing a follow-up SDS page because you did this did come with an SDS page. This was a December SDS page. I'm not sure. I don't know how
I was gonna,
reported
I
it.
looked at it. I still need to write it up, but it does have a high band, 1 or 2 at two at most. So it's not slam dunk for any immune thing, but it also is a little bit interesting that the band is there. So I actually was asking Hocamp, how often does she see that in cats when it's not ICGN?
It depends on where the band is, so I need to look at it. Yeah. Cats do weird stuff with their urine profiles. I'm just gonna say that. So I'm still learning. I'm glad we're getting biopsies on these. And yeah, we need to do a better correlation on that.
Okay, well, we were only 10 minutes over. I appreciate you guys sticking with us, and we will reconvene in April. Let me just strictly check what date it is to make sure I'm not traveling. Okay, it looks like April 21st would be our next set of rounds. I will send emails out asking for case requests. I will try not to squish into actually in very interesting cases. In one thing, maybe we'll just do an interesting case and then a gee whiz, which is what I hopefully can often sometimes add into the mix. Okay, any other questions?
And I don't know if you mentioned this at the beginning, but we are accepting lower urinary tract samples. Maybe you did.
No, I'm just wondering how many more cases we're going to be able to like squeeze in
I just
on
got
our
an
life.
email about it while we were talking. So there was a question of, are you accepting these? Indeed.
Yeah, we spoke at Lutz Lower Urinary Tract Symposium and rebranded ourselves. Dr. Lee's, we are now IVRPS plus with a plus sign. Dr. Hocamp, what does a plus sign look like? The plus stands for plus lower urinary system.
Well, yeah, y'all have done remarkably well and made it far better than I ever would have. So congratulations.
I wouldn't say that.
Yeah, I think we just have a lot of fun and we know some things. So that's pretty much and we have a passion. We have a passion. We have a great lab that helps us process these samples. If we didn't have this lab, all of this would be for naught. So
they're killing me. You're absolutely killing me.
We love you, Mary. Okay, happy St. Patrick's Day, everybody. We will see you next month.
Having great help is crucial. Yeah.
Rachel, don't log off yet.
Okay, sorry.
But stop the recording.
I don't know if I can. I don't think that's my possibility. Do you just want to call me on Teams?
No, you're fine. I just want to show you something. It's fine if it records. I just want to show you something. Watch. Do you see it?
Yay! I knitted that for Dr. Hokamp. It's almost as pretty as an amyloid.
I have an idea. I'll message you later.
Okay, talk to you guys later. See, bye.